no end and doesn't produce strain on anybody. But when you're kind of trying to do it, when you're learning, it seems a little more complicated than, or not complicated, but a little more difficult to do than it actually is. Now, the thing that you require for this is just a towel. You don't need special pads and all this, just a little towel so that when you engage the back with your thenar, or your tibial tubercle or whatever, you're not pushing in too hard. Now, what I'm going to get is to get Chris to sort of go right to the front of the chair, or to the side of the chair, because he's sitting over the edge, because I've got to get my foot up behind him here, and I'm going to be limited a little bit by the distance of my knee from the chair and his size of his back. Now, if he comes back into this position here, I can get a little lower down. Can you sit forward just a little bit more, Chris? Just, yeah. And then he can kind of slump, and I'll get a little bit higher there. Now, what I need to do is to just put my knee into the back like that. Then I'm going to ask him to put his hands behind his neck. Just let me get hold of your forearm. Put your hands behind your neck now. Take your elbows forward and just pull up like that. So that would be the technique. And I'm just trying to pull up in this way here. And it's very quick. It's not that we're sort of spending any time here. Just take your arms forward and like that. And that will be the impulse. Now I'm lifting up this way. No, the knee is just purely passive. It's just giving us a contact point there. Now the chances of us doing any clicking now, because we've been doing this quite a lot in this area, are fairly remote now. So you can let that go through your minds over the lunchtime period, and when we come back, we've got two more techniques to do here. This one, and the technique that we've just done in side lying, in extension and in flexion. And that's all we're going to do for this area. Because of course, we've got that whole variety of mobilizing techniques in this area, which give us, if we look at the whole section of stuff that we can do here with soft tissue and everything, a huge variety of techniques to do. This one I use all the time on people about Chris's size.
This one?
Yes, this knee technique. I do a lot of these. Perhaps not every day, but certainly I would do, several a week. And patients think it's going to have to be the knee technique today. Because, they can feel it and they know that all of these other things, I have a difficulty in getting to them. And as I say, it's one of these things, it's just, done, gone. And they're always very impressed with this. Wow, that was pretty quick. Sure it was. It's pretty skillful. All right, let's have lunch, and we'll be back at 1:05. Tea, yes, tea. See, I'm getting punch drunk. Okay, but that was a deliberate mistake, and Bill jumped on me there. That's very good. We've got somebody that's awake. All right, so I'm going to come back, and obviously you'll see in many of the osteopathic books where this is quite a popular technique, they use this technique fairly low down as well. You'll also see in some of them that the arms are pulled back, right back like this, which means the spine is going into extension, in my opinion. I do not think it's a technique for gaining extension. I think it's a technique for applying a distractive effort to the spine. Just stand for a sec, Chris, and I'll just pull you around a little bit there. Okay, sit down again. Thank you. So, we have the versatility only of Chris leaning back onto my knee there, so I could get to wherever this would go. I could also put a wedge or something under my foot, or a little block which would lift me up a little bit as well. But I would suggest that if you're using this technique, it should be done in this upper group here and not particularly lower down. So one of our brilliant people have brought in just the right size of pad here. So as I say, with Chris, we would come back here. You put your hands behind your neck. You'll see my back is in a little bit of a threatened position here, but I'm resting on my knee, so that tends to take away any of the real stress on the lower part of the back. Chris puts his hands behind his neck, takes his elbows forward just a bit, and I just move him like that. That's the technique. So there's not a lot of stuff happening here. I'm just in. I'll do it a little slower now. Elbows forward, and I'm coming up, and that would be the technique. That click was in his shoulder. Okay, so this would be the use of this particular maneuver, and I'd like you to sort of just practice that a little bit, see how you go along with it. Now then, just let me complete this group of techniques now, and I want you to be fairly careful with what I'm showing you now. You remember the technique that we did in sitting, where we took the head into a side bend rotated position, then we felt the lock. Now, what was important here was that the side bend was put in before the rotation, so that we don't have to rotate too much. And when we rotated, we took hold of the neck and we rotated the neck below C2. So that when if I was to ask Chris to continue to rotate, he could do quite a bit more rotation at the AA joint, and that protects the AA joint. And I'm still, because I'm only holding this, I've got a fair amount of support here. And then, of course, it wasn't because I was reefing on the neck to produce the movement. I was actually producing the impulse through the caudal vertebra, pressing on or impulsing through on the spinous process. But we have to be careful that we don't use that. And that's why I've gone away from this, because generally speaking what you see is, and I'm not going to do it on Chris because I think it's very unreasonable to do this, but you see this happen. People will do this and that will go right down to the side lever, and we don't want any of that. With our hands here, it prevents all that happening. So there is a complication that we can do without on our bad days. The technique kind of protects us against ourselves sometimes. This technique can also be done if we have a table like this, which will go up and down inside lying. Let me just demonstrate that, because the features of this are just as important as in sitting. Yes, face that way, that would be good. Now, I want you to be very careful with this technique. It's an extremely good technique, but you have to do it right. Otherwise you can cause all kinds of problems, and I see this done in our examinations quite wrongly. With Chris, he would place his hands over the side of the bed unless I were doing C7T1. If I were doing C7T1, I would probably leave T1 or leave the arm by the side, because it would stabilize a little bit. However, notwithstanding that, this is going to be the same technique as used previously. I'm going to take my hand round the neck like this. I'm going to side bend the head and rotate in that fashion. And at the same time, my hand will be round at the back here to apply the impulse, which would be there, like that. Now then, what is imperative with this is that you do not have the head supported in space without some degree of support of your arm on your knee. If I were doing that on Chris, it would be very likely that I could do that. But if my arm is on my leg and I come into that position, I can do a very nice little impulse down like that, and this is all supported. And I can do it in flexion there, or I can come into extension there. But you see, in both cases, my hand is in contact with his head and my arm is in contact with my knee, and that stays blocked to prevent any tendency for pulling him round too much into extension, or any tendency for me to bringing the neck round like that into rotation. That looks ghastly, and it is. That should play no part in experts like us doing manipulation of the cervical spine. So this in here, push down like that through that hand, and you'll find this to be very satisfactory. I probably use this more than I do the sitting one, funnily enough. I kind of like this. It relaxes the patient. I can know that I've got this support here against my arm. I find this an entirely satisfactory procedure. But it worries me intensely to see people doing it like this. Because even if they don't pull around like this on the day you see them, the chances are sometimes they'll be kind of like this and produce too much of a movement like that. Let's avoid it by giving the support and pushing down only through the spinous process and supporting the head. So the two techniques to use then, I'd like you to do the one in sitting with the knee. I'd like you to use this one in flexion, where it's not such a rigid lock, even with the non-congruency of the movement. Then we can come back into extension, which is more rigid, and you should get a little less rotation as you're trying to do this because of the inclination of the facets to sort of tighten up by contact rather better than in the flex position.
You mentioned a different position if you were going to try to do C7, T1. What was that?
Oh, I'm just saying, is it reasonable to think that we should actually stabilize T1 by having the arm laying on the arm? The problem is, if we're trying to push T1, we are saying that T1 is rotating against C7, relatively rotating, but it means we've got to produce a little rotation of T1 against T2 to get the relative movement between T1 and C7. So it may be that I shouldn't have said that, Ralph. I usually put the arm across like this anyway. I mobilize very often C7 if I'm moving C7. But it is important, isn't it, thanks Chris, to think that if we're moving T1, T1's got to move on T2 to get that relative movement against C7. So forget I ever said that. And I'm glad you sort of brought it up to let me just clarify that. Any questions on this?
This goes down to T4?
Yeah, I think you'd be pushing it a little bit, Clay, to get down as far as that. I would say that this is a technique that will get to T2. Once you get past T2, T3, then you're into the regular thoracic techniques, which are very, very efficient. So we don't need to be using the torque, I should say, let me change this, to use any of the neck lever. We're not actually using the neck lever to produce a movement, we're just using the neck lever to position the cephalic bone, and we're giving the impulse through the caudal bone. However, if we can kind of avoid that, it's still a good thing to avoid it if we can. So I would not go below about T2 with this. You might be able to get T2, T3, possibly. All right, so we're going to do the knee up, and then we'll just lay the patient down, and then we'll do the other a little bit more slowly. But don't stay any time in this thinking to yourself, oh God, oh my back, oh, you know, just in there, and done. All right, let's see it. So get everything set. All right, just in review then of what we've done, and you may have to sort of remind me of one or two here, perhaps if we didn't do them. You remember we started, yes sir, please sir. We started off with those principles where I was talking about, you know, the general stiffness in this area and the desirability of doing semi-specific techniques. And if I could get Chris to just face me, please, for a second, just to sort of review all these. We did this business where you're coming in here and doing the gentle movements here and that rhythmic movement here, which is so important as far as the muscles, the joints are concerned, and just a sort of general loosening in here, okay? We sort of looked at the possibility of doing things at the C7 joint, and one of the techniques that we used was certainly to put the arm around like this, and we can now do a side bend to the same side, and we can keep the movements, or we could actually do a little bit of a locking and a turning there, and then do a very specific movement on one level. Or, as I said, we could use a semi-specific procedure where we allow this to come into its coupled movement, and then we could do extension and rotation with side bend to the same side as the rotation. This lends itself so well to a whole variety of movements, and particularly if we had one of those chairs that pull up, the Saba kind of system that sort of comes to this position, it makes it a little bit easier to do, of moving into here. You remember last night that we had a look at a couple of techniques, just to review those, where I could put the patient on the back, and I could do a forward gliding motion pulling up with a translatoric movement here. I could hold the shoulder down and pull forward with a little kneading action on the C7, pulling it forward. We did discuss the business of should it be coming forward or is it likely to be forward, and I think that is a sort of a case in point. So if I asked you, could you think of a technique of massage that would take it back? Of course you could. You could come on this side, for example, and I could just start taking it back like that, and instead of pulling the shoulder, stabilizing it backwards, I could bring it forwards and just do it like this and take it back on that side. And that's what we should be doing. Not just sort of thinking to ourselves, you know, what did that guy show us or what did that woman show us? We shouldn't be thinking of that. We should be thinking, okay, they showed us that, what was trying to achieve. Now, is there any other way I can do that? And so you do it, yeah. And that's it, and you might come up with a better system. And this is what we have, that Diane's got one or two different ways of putting the arm against the body. Okay, this has worked well for her, and perhaps it had worked well for me with patients that I've had a bit of difficulty struggling through one arm to do it. And this is what we should be doing. We should be learning from each other, modifying our techniques, and as the time goes on, more and more modifications take place till it becomes presumably the best that can be. But in taking this one backwards and the shoulder forwards like this fulfills the bill. I think it was Clay that made that good observation about should we be taking these backwards? Probably we should. And this fills this bill perfectly well, doing a translatoric movement in that way. Then we sort of said that stabilizing of the upper thoracic is very useful when we're trying to do C7, T1 or C6, C7. Can you lay on your stomach, rest on your elbows? And this we can come into a slightly flexed position, pulling around like that. I don't try and remember which side does my thumb go on. What I say is as I come round here, if that's stiff, this is immediately wanting to go into right rotation, so I stop it by putting it on the left-hand side rather than trying to remember which side. Just look and see, okay, that's moving that way. This is the way that I will stabilize that. And we saw that we can very usefully, same movement, it's still right rotation, but it's right rotation with the extension backward gliding joint. And I can come around, think of my hand in this way. I'll still be on the same side of the vertebra to stop the vertebra moving into right rotation, that is the T1, and I can work round here. I make sure though that it's a very local extension. I don't just sort of pull the head up like this. Okay, this is what we've got to be careful of, and this is why in what I find so satisfactory about the Norwegian system, that you kind of wrap yourself around the patient. And so that I'm sort of thinking about the movement here through my body almost, not kind of it wobbling about like this with no contact. It's a very intimate kind of treatment. Our central nervous systems are coupled in with the central nervous system of another person. That's pretty intimate stuff. And when we come back into this, if something is happening that doesn't feel quite desirable, I could kind of come round and we change from this. I say to Chris, okay, could you look a little bit to the right and above your head as you do this? And that immediately helps, because it got worse today. And what was happening was, he was quite interested in something on the floor down here, which we was looking at. And if you could look at that very interesting thing down there. Okay, and I'm pushing here and it's really stiff. Look at it, that's it. Now look to your right and over your head. And immediately, that eye reflex movement makes a huge difference there. And we should be sort of thinking about things like this and sensing what is going wrong. Okay? So, this is sort of very important. And these are modifications of these techniques. All right? Ned. Right, let's have you up here a bit, Chris. Arm over the end of the bed. Laying and facing me, please. I didn't think it was as great as that at that point. That was rather ridiculous, huh? Okay, so we're coming back like this, okay, into that extension motion there. And as I said to you, we can extend it like that, or we can backward glide it like this. And we can get this backward glide quite a long way down the back. If I keep my hand like this, with my thumb behind the occiput and my fingers down here, I can actually get the movement right down to about T4, perhaps even T5, like this, without putting a tremendous degree of strain on the neck. Chris, can you take your head backwards further. See all this movement of extra extension he can do? That's all safety. And that's what we should be trying to build in, so that within these levers, we're not building up too much torque. Can you lay on your back now? Then we did the distraction techniques with the wedge or without the wedge. Coming into here. Up here, I keep it up there. And I can, with Chris, I'm at full arm stretch here. There. You can actually do it from the similar side and come around and do this. I don't find that as satisfactory myself as going the other way. I would prefer to use a wedge rather than doing it in reverse action. We can backward glide and distract in this position or in that position. And so these are the techniques that we've done in this area. There's a whole group of them that we should be doing. And this will be of enormous benefit to many patients, particularly if once we've done this, we couple it in with what's happening to the first and second ribs, what's happening to the muscles, and we're particularly interested in the posterior cervical muscles, the length of the ligamentum nuchae, because if a person has got tightness here, there's no way that you're going to be able to straighten them here if you don't do something there. Else they're going to be walking like this. And they're not going to do that, they're going to go back to this. So it's one of these things where it's pointless just treating sort of one area. And most of this is a very, very stiff group. And so mobilizing over a period of time, particularly with muscle stretching and muscle action, is going to be the order of the day. Very good area to treat, big challenge, not treated well out there by lots of people. And I think we have got such an excellent group of therapy treatments here with concepts that we should be able to change the world. Perhaps not the world, but our little world. Okay? So those are the things. Now, are there any observations or comments or queries that anybody might have on any of those? Sandy.
What if for some reason you can't use the arm, either frozen shoulder or reflex sympathetic dystrophy? It kind of makes the thoracic area a little bit hard. I mean, I've been trying to think some of the things you just do one, like that one arm thing, but crossing the arms on their chest. And,
you could usually get a bad arm into this position, can't you?
well, if you can touch it.
Okay. Well, let's say we can't. So I'm going to put it in this. And I'm going to take this one up into this position here. And actually, by blocking here and getting onto here, I can actually do many of these things through one arm. I often do this. So that's a possibility. It's a possibility particularly when we use the wedge to do that. The question now is, could we be doing some of these prone techniques in that particular situation? I don't like prone techniques myself particularly. Could you go onto your stomach a sec, Chris? The things that we've just done around here, we don't need the arms all that much for. We could not particularly do manipulation, but we can come into, let's say, the one where we were in the side-lying position. I was rotated and I was supporting Chris. I could place him in this position, either in extension, where I could do that a little, or into flexion, where I drop the table down into this. And I can come over just a fraction, Chris, so long as you keep your head on that thing here. And I can come into a position here, put a little traction on the neck like this, and then a little impulse through here. It's quite hard, though, I reckon, to give an impulse sufficient to cause a manipulation in this position when your arm is in this position. I doubt that most of the women could do it. You need to sort of get in line and everything is rigid, whereas in this position, the linkages are very often in the open pack position, so they're not really very efficient. So, you could kind of work on this and go to the other side, and, I think this is what we all do from time to time. Wonder, can we develop a slightly different procedure here? Well, that's kind of nice on your bad days. I know sometimes you do come up with something, you think, great, that's me. Or, coming around here using your pisiform attachment like this. So there are looking at the problem, then, like Sandy said, so what if you've only got one arm that you can use? Okay, then what we have to say is, how can we adapt this for this particular person? And can I just do it through a one arm, especially if I kind of perhaps put, a pad of a towel under here so it gives me the right feel of where the arm should be normally, and then I don't want to put too much stress on the shoulders, so I'm going to pull a little bit more from the back and perhaps do a little bit more of a posterior glide. That's how I look at that. And I often do one-arm techniques in patients that have, can't stand this. If you've got hypermobility of the AC joint, and you can sometimes feel it sort of go, you don't want to do this and get this big crunch in the AC joint, and then you've got a sore AC joint to deal with. Occasionally, the lever system absorbs a little more stress in a way that you would rather not have done, and sometimes you have to address that. Not very often, not very often. That's a sort of really good point. Any other things? So here we have the principles. You have the knowledge and the principles under control. You're developing some of these rapid little movements now, and I would suggest that you stick with these techniques at least for some time, not just immediately change everything, because these have stood this test of time. But it could be that some of these need to be changed for you. And that's why it'll be good with a study group that continues, and Anne and Chris around to sort of talk about some of this and see whether you can come up with acceptable alternatives, because you can't do it quite like that. We've got Suzanne, whose thumb she pushes through here and the thumb belt bulges out. Well, she's going to have to do something to sort of try and offset that, or think of some other way of contact. We couldn't think of it just here, right off the top of our heads. She'll have to work on that a bit, or make herself a little splint. Because you're going into this after this course, making these, aren't you? So here we are from this course. I realize I know nothing about this, and I better learn how to make a few of these, because I've been very inadequate with the CMC joints of the thumb that I've treated. That's why I don't like treating them, probably, because I haven't been making these things. And so this is what is so good about this course, because you pick up all sorts of things from people. Oh, what are you doing with this? All right, I'll try that. Nothing to do with the teacher, but it's to do with this active interaction that goes on, and that's what's so good. All right, let's just stop that. I'll give you 2 or 3 minutes, and just in case you want to do a little bit of active recall or write anything down about any of those techniques, because I know by 2 weeks' time you'll think, God, what did we do for that area? Did we do it at all? I wonder if we missed it, So if you want to spend 2 or 3 or 5 minutes just writing anything down for that, then we're going to go back to the lumbar spine, and we'll have a quick review of that. Yes? Okay. One of the problems that I think we have with the lumbar spine, and this is not particularly an answer by manipulation either, is to think about the situation where we've got the following. Let's say we've got L5 like this, all right, and we've got L45, which is hypermobile. I'll just put plus. Okay, and we've got the lumbosacral junction here, which is hypomobile. Now we know that we should try and get this supported within the upper lever. And perhaps if it's not unstable, we